Hi, I'm Dr. Aaron Kowaleski. If you are watching this video, it's probably because you have BPH and are interested in prostate artery embolization. So this video is really going to give a breakdown of the medical condition, the treatment options, and then what we offer here at ECCO Medical. If you do have a diagnosis of BPH, most likely you're suffering from urinary urgency, which means you have the feeling that you need to urinate all the time. Frequency, which means you need to go quite often, maybe even 5 minutes after you went the last time. Nocturia, which means nighttime urination, which can happen multiple times, which makes it difficult to get a good night's rest. So you may be tired all the time from the amount of times you have to go at night. You may also have pain with urination, or you may really have to strain in order to empty your bladder. BPH, or benign prostatic hyperplasia, is a pretty simple concept to understand. It's the gland that lives right next to your bladder, and it can slowly enlarge over time, which would then cause your symptoms. Most important thing to know is really that first word or that first letter in BPH, which is benign. It is not cancerous, and it's not known to be associated with an increased risk of cancer either. So who gets BPH and why? The two known risk factors for BPH are: one, being male, you have to have a prostate to get an enlarged prostate in the first place, and two, testosterone production. So it's not well understood why the prostate enlarges, but we do know that testosterone stimulating the gland does lead to its overall enlargement. Also, age. The older you get, the more likely you are to have prostate enlargement. The numbers are about 50% of men over the age of 50 have it, 60% over 60, 70 over 70, etc., where at about 80 years of age, 90% of men have it. The general consensus is that if you live long enough, you're going to get an enlarged prostate. So let's talk about where the prostate is and what its function is. So the prostate is about a walnut-sized gland that lives between your urinary bladder and your external penis. So it's inside your pelvis, and it surrounds the urethra, or the tube that you urinate through from the bladder. So that prostate, as it enlarges, it can pinch down on that tube to make it difficult to urinate. The function of the prostate is to secrete fluid for ejaculate. So if you have an enlarged prostate or a poorly functioning prostate, you may not be able to produce any ejaculate, or you may have what's called reversal of ejaculate, where it goes into your bladder instead because it can't leave through the urethra due to the prostate. So if your primary care physician or a urologist or someone like me, an interventional radiologist, is wanting to diagnose you officially with BPH, there's a lot of things that we do. So one of the things is surveys, specifically the IPSS, which is the International Prostate Symptom Score. It's a series of 7 questions where you answer about your symptoms on a range of 0 to 5. 0 meaning you don't have that symptom, and 5 meaning it's severe. On top of that, there's a quality of life where we want to see how bad these symptoms are affecting your quality of life in your day-to-day. Other things that we can do are ultrasound of the prostate to look to see if it is enlarged, or MRI, where same thing, we could look to see if it's enlarged. Cystoscopy can be performed by a urologist, where they put a camera through your penis into your urethra and into your bladder, and they can see if there's impingement of the urethra directly by your prostate. A couple other studies that may be performed are functional studies that let us know how well your bladder is working to be able to evacuate and urinate normally. So one of them are uroflowmetry studies, where they look at the velocity and the volume that you urinate, and then also something called post-void residual, where they take an ultrasound of your bladder before you urinate, and then one afterwards to see how much is left in there, to see if you are able to urinate fully and empty your bladder. Treatment options for BPH, there's a pretty wide variety. It ranges from conservative or non-invasive things like medications all the way to major invasive surgeries. So let's just walk through them. Medications are going to be first-line therapy. Once you have symptoms due to BPH, usually you're going to be started on something like tamsulosin or Flomax, or the same medication. That medication helps relax the bladder muscles and also the muscles surrounding the prostate to make it easier to void. Other medications that you can use are going to be two medications, finasteride or dutasteride. They're both the same class of medication. And what they do is they block the pathway of testosterone production. Since testosterone is known to cause BPH, this can decrease testosterone production and thereby halt the enlargement and maybe even slow it down a little bit, which would also help you with your symptoms as far as being able to urinate and not have nocturia and things like that. So those are the medication you can do. You can also do an over-the-counter herbal supplement called saw palmetto, which is also a first-line therapy. But moving into the more invasive things. So there are numerous surgeries that they can do that are less invasive. One of them is TURP, TURP, or transurethral retrograde prostatectomy. That's where they take a cystoscope or a camera, they go into your penis and through to get into your urethra, so that way they can visualize the enlarged portion of the prostate. There is a razor, or some may say roto-rooter on there, and that's where they go through and they cut through or shave out the enlarged portions of the prostate. Complications there are going to be bleeding and impotence, because there is a chance that the nerves that let you achieve and maintain an erection can be damaged. Has about an 85 to 90% success rate as far as symptomatic relief. Another procedure was done in a very similar way, but instead of shaving the prostate out, it's called resume or steam. And that's where they put the camera in the exact same way, and they steam the prostate to shrink it down and kill some of the tissue. This has a similar complication profile to TURP, just because that heat can damage some of the surrounding tissues. Also, there could be numerous treatments depending on the size and the amount of relief that you get from the initial treatment. So typically patients are going back for 3 to 5 treatments with Resume. Another procedure is called Urolift. Urolift is when they go in and they put in some stay fasteners, which will squeeze the sides of the prostate shut. That camera will have a needle port out of the side, so the needle will go out of the urethra into the prostate. They'll leave that fastener behind and then cinch the prostate down. That's not going to have the complications of impotence or as much bleeding. However, it does have a little bit higher recurrence rates than the other treatments. Next is going to be what's called green light laser. Green light laser is usually reserved for when the prostate is too big for those other treatment options. So size of prostate is very important to evaluate on the front end, because it lets you know what treatment options you're a candidate for. Green light laser is, again, go through the penis into the urethra, and then a laser is used to shrink down and help destroy some of that prostate tissue. There's another kind of laser called an FLA laser. That is when they go through the rectum for the laser, and you can use an ultrasound to see the prostate through the rectum, and you laser through the rectum into the prostate. Now we talk about what we do, which is prostate artery embolization, which is an endovascular procedure, so it's quite a bit different than those other options. So we don't have to go through the penis or into the urethra. We go through blood vessels instead. We can do a needle puncture through the wrist, which causes minimal pain to a patient and a shorter recovery time, and then we can just navigate using X-ray and ultrasound guidance to treat the prostate. As far as results of all of these things, they all have a very similar result profile, in that 85 to 95% success rates for all of them. Every single one of these treatments, no matter what, has some degree of recurrence, meaning that your symptoms can return after these procedures. When you look at the literature, when you do your Google searches and everything else, you're gonna see that the recurrence rates kind of range anywhere from 15% to 10%. So across the board, success rates are about the same, but also recurrence rates are about the same. If you do have recurrence of symptoms, then your options are to do another procedure of the same kind that you had in the first place, or switch to a different one and see if you get better success rates with that. Regardless, if you do need a second procedure, the success rates for the second procedure are usually a little bit higher than the first time, because if you look at it, it's the first time they kind of did the majority of the legwork, and as it came back, they were able to treat what was residual there. So as a person who performs PAE and treats prostates, I'm always going to be a proponent for what I offer to patients. I think one of the most important takeaways when you're trying to choose what sort of treatment you want, PAE has no risk of impotence, which the majority of other treatment options do. There's significantly less risk of bleeding, and it's usually a shorter procedure with a shorter recovery time. and you go home the same day. On top of that, complication rates are significantly less. For prostate artery embolization, complication rates are only about 1%, and they're going to be quite a bit higher with the other procedures. So the way that we perform prostate artery embolization, it's done in our office. We don't do it at a hospital. We do it with moderate sedation and not general anesthesia. So we don't put a tube down into your lungs to breathe for you. It's the same medications that they use for colonoscopy. Usually if you're getting a PAE, you're of the age where you've had a colonoscopy before, so that'll probably make a little bit more sense. Don't necessarily remember the procedure, but you're very, very comfortable throughout the entirety of it. You recover here in the office for about an hour after the procedure, and then you go home. So the way we do the procedure, I typically go through the wrist. There's a blood vessel in your wrist that you can feel with your 2 fingers. It's on the side of your thumb. We use ultrasound guidance to see that needle, do a needle stick into that artery after we numb up the skin so you don't feel it. That needle is hollow, so then we thread a wire through that needle into the blood vessel. That wire we can see on x-ray. So then we're using x-ray at the same time, and we can guide that wire up using x-ray up your arm. We take a left-hand turn at your shoulder, go down your aorta and into your pelvis. Once we're in your pelvis, we can thread a little tiny tube, less than 2 millimeters in diameter, over that wire. And then once we're in the pelvis, we can inject contrast. Some people call it dye. It is essentially an iodine salt water that reflects x-rays so we can see it on our screen while we're doing the procedure. With the equipment that we have, which is some of the most advanced in the world probably for doing these procedures, we can create a 3D roadmap or GPS of the vascular system of the pelvis. So we can see every single blood vessel in the pelvis and then select the map or the pathway into the prostate arteries to go in and treat the prostate. Once we guide that wire and tube or catheter system into the arteries, feeding the enlarged portion of the prostate, then we inject these little tiny beads that are so small you can barely see them with the naked eye. They travel with the blood into the capillary beds that are providing the oxygen exchange for the enlarged portion of the prostate. Once those beads lodge there, it prevents any more oxygen exchange or nutrition supply to the prostate, so it does shrink down, and therefore the symptoms get better as the prostate shrinks down, allowing that urethra to be open and for urine to be evacuated normally out of the bladder. So for this procedure, we prescribe you a handful of medications that you should take after the procedure. It just helps with the recovery phase, shortens it, makes your life a little bit easier. After any embolization procedure of any kind, whether or not it's in the prostate, whether or not it's in your liver or anything else, there's always a phase of some inflammation in the organ that we treat afterwards. So we prescribe you some steroids to help decrease or just prevent that inflammation altogether so you don't have that. Other medications we will prescribe are going to be Flomax or tamsulosin. Some of you may already be on that medication, so we would have that continued for a little bit afterwards, just to continue to provide that sort of urinary relief while the PAE can start working, because it does take a couple weeks for the PAE to give you results. We also prescribe an antibiotic just to decrease any risk of any kind of infection like a urinary tract infection after the procedure. Following the prostate artery embolization procedure, what you can expect from a recovery standpoint, there may be some light tinged blood in your urine, maybe some light tinged blood in your stool coming from your rectum. All self-limiting, usually goes away within a couple weeks. You can have some bladder pain when you're trying to urinate. That will also go away. We do give you medications to help with that in the recovery period as well. For the most part, you start seeing results about 2 weeks after the procedure, and then you continue to see improvement for up to 12 weeks. The majority of your improvement is going to be in that first month. If we need to put numbers on it, I would say if you get 100% of your improvement at 12 weeks, you get about 70% of that improvement in the first 4 weeks after the procedure. Okay, so let's talk about the scary stuff that no one wants to talk about, but we have to mention it because I believe that every patient, if they're going to seriously entertain a procedure, they should be well educated, not only on the benefits of it, but also the potential bad outcomes. So I'm going to say this now, I'm going to say this at the end. The most important thing to understand is that these complications happen less than 1% of the time with this procedure, and they go away on their own within 30 to 45 days. So the arterial anatomy in the pelvis in men and women is very complicated, but in men, these vessels are very small. And sometimes blood vessels that feed the rectum, the bladder, or the skin of the penis can actually be also providing the prostate itself. So when we go and inject these beads, sometimes some of those beads can get into these arteries. So if there's an artery coming out of the prostate and going to the rectum, and some beads get into that artery that feeds the rectum, you can get some bleeding from your rectum. It can be pretty scary, of course, but the most important thing to understand is that's what we call self-limiting, meaning that it goes away on its own without you needing any further workup or any further treatment. And that goes away in that 30 to 45 day period. Similarly, if there's an artery that's coming out of the prostate or really near the prostate that feeds the bladder, and then some of those beads get into the artery that feeds the bladder, that can cause some bladder spasm and some bladder pain. Okay. Similarly, that goes away within 30 to 45 days. You may get some blood in your urine, some blood from oozing along that bladder wall from where those beads got in. Probably one of the ones that's the most visually scary is going to be if there's an artery that's feeding the skin of the penis and some beads get into that artery and then cut off the blood supply to a portion of the skin of your penis. What happens there is you get an ulcer on the skin. It's not this big ulcer, but it runs along the distribution of that artery. It's very rare. Again, happens less than 1% of the time, and it goes away within 30 to 45 days with no long-term complications. If you get on Google, you're going to see some stuff that you can't unsee once you see it. So feel free to look at it, but please just understand that it does happen less than 1% of the time. It goes away within 30 to 45 days. And one of the things that's super important in being able to prevent these sorts of complications is the fact that docs like myself need to use the most advanced equipment that's out there. That way we can map out the blood vessels that are in the pelvis and do everything that's necessary to prevent those beads going into the wrong area. With the equipment that we have here at ECCO, we've got the best in the nation, some of the best in the world. We are the only outpatient center that has this sort of equipment, and it is by far and away the best form of navigational software and imaging that you can use for this sort of procedure. So if you do have any of these complications that we mentioned, we would be managing it here at ECCO. So it's not like you get it and we just say, see you later. So the rectal bleeding is very rarely painful. However, it can be, and so we would be able to prescribe you some medication to get you through the painful portion, which is usually early on. The skin ulceration of the penis is typically not painful. It's just visibly alarming, as one would guess, but typically it's not painful. If it is painful, we would be able to prescribe numbing creams and medications like that for it. And then the bladder pain, there are medications that help out with bladder spasm that we would be able to prescribe you as well. Thanks for watching this video. It may have run a little bit long, and I hope it answered a lot of your questions. You're going to be following up with someone at ECCO to answer any further questions should you have any. And otherwise, I'll be seeing you on procedure day.